Welcome to Partners in Pancreatic Cancer. My name is Koushik and I'm in the Division of Gastroenterology at the University of Pennsylvania. I'm often asked, who are the patients that would benefit from pancreatic cancer screening? As the risk of pancreatic cancer in the general population is quite small, estimated in the SEER database to be about 12 to 14 per 100,000 patients, efforts to screen pancreatic cancer have focused on populations of patients who have a significantly higher risk. There are several common environmental factors that increase the risk of pancreatic cancer, most notably alcohol and tobacco use, but these aren't sufficiently elevated in risk to warrant additional screening. The two overall situations where pancreatic cancer is at sufficiently elevated incidence to warrant screening are in patients with a known or suspected genetic predisposition to pancreatic cancer, or in those with a history of hereditary pancreatitis. Reviewing first the genetic syndromes that are associated with pancreatic cancer. The first to talk about are non-syndromic patients, that are patients who don't fit into well-established syndromes of pancreatic cancer or other types of epithelial cancer, or who don't have known mutations. Having a single first-degree relative with pancreatic cancer carries no increased risk of developing pancreatic cancer. Having two first-degree relatives, however, increases the risk to 6.4-fold, and having three first-degree relatives increases the risk to 32-fold. This is outside of the context of a known syndrome. The first syndrome to talk about is familial atypical multiple mole and melanoma. In this syndrome, there's a 13 to 22-fold increased risk of pancreatic cancer, with about 17% of patients developing PDAC by the age of 75. This syndrome is due to a germline P16 or CDKN2 mutation, which inhibits cyclin D1 CDK4 or CDK6 complex. Germline CDK4 mutations in the P16 binding domain have also been described. More than two members with a melanoma is generally needed to make this diagnosis. Second syndrome are BRCA1 and 2 mutations, more commonly seen in clinical practice. These syndromes are associated with about a 3 to 4-fold increased risk of pancreatic cancer from the general population, more so with BRCA2 than BRCA1. Mutations in tumor suppressor genes on chromosome 17 and 13 that are passed autosomally dominant and normally help repair double-strand breaks in DNA are the cause of this. Peutz-Jegher syndrome is associated with a 132-fold increased risk of developing pancreatic cancer of a wide array of subtypes. Mutations in the LKB1 protein are the cause, and there are important interactions with P53 and BRG1. Peutz-Jegher syndrome is classically associated with hamartomatous polyps of the colon and mucocutaneous pigmentation, but it's important to know that there are other cancers associated with this syndrome. Finally, HNPCC or Lynch syndrome is associated with about a 2 to 4-fold increased risk of pancreatic cancer. Mismatch repair gene mutations MSH2, MSH6, or MLH1, PMS2 interfering with proofreading function of DNA are the cause for this syndrome. About a third are MSH2 or MLH1, and a minority are due to MSH6 or PMS2. These patients present with colorectal cancer at varying ages, and it's an autosomal dominant condition with 80% penetrance. Pancreatic cancer, while associated, is less common. The second category to discuss increased risk of pancreatic cancer is hereditary pancreatitis. These patients have about a 35-fold increased risk of PDAC compared to the general population. Hereditary pancreatitis is autosomal dominant with about an 80% penetrance, and it's interesting to note that there's a markedly elevated risk in pancreatic cancer in these patients with concomitant alcohol use or cigarette smoking, speaking to the interplay between both genetic predisposition and environmental factors. Classically, this condition is due to mutations in cationic trypsinogen PRSS1, with premature activation of trypsinogen causing repeated bouts of pancreatitis. So the question comes, who should be screened? International consortium was convened, and guidelines were recently suggested in the CAPS protocol. And the International Cancer of the Pancreas Screening Guidelines, or CAPS, have suggested that the patients who should be screened are those with 2 or more affected blood relatives, at least one of which be a first degree, those with Peutz-Jegher syndrome, and those with either a P16, BRCA2, PALB2, or HNPCC mutation with at least one first or second degree relative with pancreatic cancer. In terms of when to start screening, this is much more up into the level of expert opinion, and the thought is that those patients with familial pancreatic cancer should start around 45, and those with Peutz-Jegher syndrome should start at age 30. And in terms of how to screen, the methodologies are currently limited to MRI and endoscopic ultrasound. Thank you for viewing this activity. For additional resources, please view the other educational activities on partnersinpancreaticcancer.com.